Hello, everyone. My name is Erin Morgan. I am the editorial director of Contact Lens Spectrum and the Eye Care Business magazines at Broadcast Med. Thank you for joining us today. I am going to be moderating a really cool session today with some very special guests. This is for our Improving the Continuum of Care with special guests, Dr. Carolyn Major and Dr. Yasha Modi. Dr. Major is an accomplished optometrist and recognized expert in OCT angiography, and retinal disease. She is based in Oklahoma, and she is the residency director at the Oklahoma College of Optometry and a member of the Optometric Retina Society. Dr. Modi is a board-certified ophthalmologist in New York, specializing in retina and uveitis and vitreoretinal surgery. He is an associate professor in the Department of Ophthalmology at NYU Grossman School of Medicine. Welcome to both of you. Some incredible, very honored to be here with you both today, very accomplished folks. So thank you for joining us to share your focus.
Thank you for having me. Such a pleasure to be here.
Yeah, always a pleasure. And Dr. Major, it's always, I just love working with you and I love having these conversations. So looking forward to today.
Thank you. That's fantastic. Well, we're looking forward to sharing some good information with our viewers. Today, we're going to be discussing the progression of age-related macular degeneration, what to look for, and how to determine when dry AMD becomes wet AMD. We will explore the critical role of OCT, OCTA in detection and diagnosis, and review how ophthalmic software can help clinicians monitor and manage patients over time. So we'll get started with our interview questions. I'm just going to go ahead and roll through them. To begin, let's talk about diagnosing AMD. Dr. Major, would you say it's true that patients undergoing dry AMD therapies are at a greater risk of accelerating to the wet form of AMD?
Yes, so we do know that there's an increased risk for macular neovascularization to potentially develop in individuals undergoing complement inhibition therapies for geographic atrophy. And this was true for both the clinical trials evaluating the safety and efficacy of SAVOVRI as well as ISURVEY. And in the Oaks and Derbies trials, where they were evaluating the safety and efficacy of SAVOVRI, there was a dose-dependent increase that was seen in the risk for macular neovascularization at the 24-month mark. So the conversion rate was about 12% in eyes that were treated monthly, 7% in eyes being treated every other month, and then 3% in the sham group. Wow. So I think that really speaks to us that it's important for us to still diligently monitor patients for conversion to neovascular disease, even when they're being treated with complement inhibition therapies. And that it's like a continuum, right? That geographic atrophy and neovascular AMD aren't two distinct separate entities, that they can occur within the same eye. And we need to pick up on that because these are patients who can then be treated with both complement inhibition as well as anti-VEGF. And I think Dr. Modi could speak better to that than I can.
That's fantastic. Well, thank you. That's really fascinating. I'm curious if there's a clinical advantage to identifying the conversion early.
Oh gosh, yes, absolutely. Multimodal imaging, I think, especially like OCT, facilitates our ability to detect the earliest exudative neovascular conversion possible, that then allows us, kind of as the primary gatekeepers in eye care, to refer promptly to a retina specialist for anti-VEGF treatment when the vision is still good and we can keep it good, right, and prevent further vision loss over time.
That makes perfect sense. So it is that identifies a patient's conversion to wet AMD that you just mentioned, the OCT.
OCT is a very important tool, but I think it's just one of those like tools we have in our tool belt. There's a lot of things that you need to consider. So really the features of that conversion to neovascular exudative AMD may be hemorrhage, which doesn't show up very well on OCT, but is probably best detected by color fundus photography or ophthalmoscopy. Whereas something like fluid, especially like subtle subretinal fluid or intraretinal fluid, is going to be best detected by OCT as opposed to, say, like ophthalmoscopy. And then other features that are important to look for, I think, are pigment epithelial detachments, particularly like fibrovascular detachments that are shallow and kind of irregular contour. serous or hemorrhagic pigment epithelial detachments, exudate, or an OCT angiography, we can pick up neovascularization before it becomes exudative and has fluid or hemorrhage associated with it.
I see. Right. Thank you for that. Would this be visible on a standard structural OCT?
Yeah, so structural OCT shows us like the secondary effects of these neovascular complexes, like fluid and like tissue and retinal layer alterations. But really, OCT angiography is beautiful in the sense that then we can directly visualize the membrane itself and therefore detect neovascularization before it becomes exudative and exudes fluid.
That makes sense. Thank you for that. And Dr. Modi, do you agree? Any input there on that
Of course. So
assessment?
realize that when we're talking about the treatment, just for the audience, it's helpful to realize we're talking about advanced atrophic AMD. So we're talking about the end stages of dry macular degeneration. And when these people are getting therapy, they are either getting it either monthly or every other month. And actually, in the Derby and Oak study, it was studied in both monthly or every other month. And then in the essentially the studies with Avastin capsid pegol, it was studied only monthly for the first year, and then it went into an every other month extension as a possibility. And that's when we really learned that there was sort of this dose-dependent response. In fact, actually in the phase 2 study, they had recognized that, and they actually had pulled people out of the study because they were so concerned. So you had actually brought up a point where, like, how worried should you be if they convert to exudative disease? Well, we know that patients can drop vision really precipitously once they convert. But at the same time, especially when we're talking about a continuum of disease where we have progressive atrophy and then potentially progressive like neovascularization with exudation, it's worthwhile to consider treating both of them. And I think we're sort of figuring out the playbook right now. Like, how do we do this? How do we give somebody complement inhibition? How do we give them anti-VEGF therapy? What are the intervals? And I think that's where every patient is slightly different.
Perfect. Yeah, that's wonderful. Thank you for explaining that. So, Dr. Modi, do you monitor actually AMD patients in your clinic,
Yeah.
or do you utilize a local network of
So
optometrists?
I guess in the beginning, when somebody has like, for instance, like intermediate AMD, where they have sort of drusen and then pigment changes being on the later end of that sort of vast intermediate spectrum, those are patients that maybe not necessarily are in my clinic. And so regular follow-up of those patients is actually going to be really critical, where we follow them every 6 months. And I think that could be done in conjunction with our colleagues in optometry, ophthalmology, retina. It depends on the practice pattern in the area in which we all live. But I think that's something that we can all uniformly screen for. And that's why I think education on understanding what does it look like when we see neovascularization, what does it look like when we see exudation, which is obviously a little bit easier. And to a point that Dr. Major brought up, when you're trying to identify neovascular non-exudative disease, that's oftentimes the hardest thing for sometimes optometrists and general ophthalmologists to pick up on. But it's really important to identify that, because those are sometimes the patients at the highest risk for progressing to exudative disease.
I see. Thank you for that. That makes sense. Do you agree then that collaborating with other physicians can really benefit the patient and the practice workflow in these circumstances?
Absolutely. Absolutely.
Yeah.
Yeah,
Yeah.
there's no doubt about it, right? Like,
Great.
I mean, what are we trying to do? We're trying to prevent vision loss. And wherever patients can
Right.
get care, that is really where we
Right.
want them to be. And we want, like, the best
Sure.
part of working with, like, Dr. Major is that she is so well informed, right? And like, if she was in my backyard, I would just be like, all right, just tell me what to do. and and it would be really great. And I think that's why we're having these educational symposia, to sort of go and say that there's so many ways to do this, and this requires picking up the phone, calling your docs in the neighborhood, and say, how do we do this in the most efficient manner?
Definitely. It's wonderful to have a great care team, kind of however that the patient enters, into that vision experience. So just a curious, Dr. Major, kind of, do you agree? Have you collaborated with ophthalmologists or retina specialists, and how has that impacted your own patients' care?
Yeah, definitely. I think for any real serious disease entity in eye care, optimum patient care takes place when healthcare providers and professionals really work together in patient management. And here, I know we're talking about, optometrists as well as ophthalmologists, retina specialists, but low vision specialists often come into play with regards to the management of patients with like end stage and vision loss from macular degeneration as well. And so I think there's so much we can offer as a team together for the patients. And I like to, have a close working relationship with the retina specialists that I refer to and understand like what they want me to refer, what sort of treatments may be considered. That way I can make well-educated and informed referrals to them.
Wonderful. So is collaborative care part of your own residency program?
Oh, absolutely. I mean, that's really a value that we try to instill in the residents is how to make appropriate referrals and how to communicate the necessary information to that next provider that's going to make the most benefit in terms of what they need to do and what they need to know to make their own informed treatment decisions.
Fantastic. So a quick question here on this topic. The ZEISS Forum Cloud Viewer, that can help facilitate collaborative care between primary and tertiary eye care providers.
I haven't personally utilized it, but I think that it would be an excellent platform, especially I practice in Tahlequah, Oklahoma, which is like a really rural setting. And so a patient has to drive about like an hour, 15 minutes to get to the retina specialist. If it's something where maybe I don't think a patient necessarily needs treatment, but I just need like a pat on the back saying, yeah, you're right in this diagnosis or something, I think that would be really valuable.
Fantastic.
Yeah, and when you think about treatment, the other thing to think is sort of when we say, hey, yes, I think you're a good candidate for complement inhibition. I think, well, maybe retina specialists, we don't all necessarily agree on who ought to be treated. I think there are some people that we uniformly agree on, and those are patients with enlarging extrafoveal lesions. And how do you know that they're enlarging? Well, you know that they're enlarging because they've been in Dr. Major's clinic for 2 years, and she has this near infrared imaging, autofluorescence imaging, fundus photos, that works to prove that to me. And a way in which you can digitally provide me that information, well, that sort of greatly enhances the conversation and helps me make a real-time decision on what we're ultimately going to end up.
Definitely. Absolutely. That's great feedback. So how, looking at the OCTA from ZEISS, how would you combine the data received from advanced RPE analysis and the volumetric data from Angioplex OCTA from ZEISS to diagnose and manage non-exudative and exudative AMD?
I think both OCT angiography and the advanced RPE analysis are really powerful in different ways. So, like clinically, I'm primarily using the advanced RPE analysis and specifically the sub RPE slab, which is looking at like an in-phos view of choroidal hypertransmission that occurs in geographic atrophy. And so I'm using that to detect geographic atrophy and then monitor progression over time. And then also sharing that information with the retina specialist when I make a referral for consideration of complement inhibition therapy. Whereas OCT angiography, its real highlight is showing neovascularization even prior to those exudative features. So using OCT angiography to try to detect neovascular disease, and then the advanced RPE analysis to detect and track geographic atrophy, I think is a wonderful and beautiful combination of trying to detect all of the things that I would potentially need to know to refer out to a retina specialist for treatment.
Great.
And as a retina specialist, it's also easy to kind of follow these patients too. So in addition to the qualitative sub-RP slab, which I also find is the most valuable slab, is the ability to apply quantitative metrics to that. And you can measure the area change over time through the algorithms that have been developed. And you can also measure the distance to the fovea, which has also been done. So those are sort of two sort of ways in which you can sort of show your patient, one, how these lesions are enlarging, and then two, what we're trying to protect, which is the fovea, and how far away it is from the fovea at each visit.
Great. I have one other kind of related question here for either doctor or both of you. With the ZEISS angioplex, a single scan captures both 3D structural and microvascular information. I know we've kind of discussed that a bit previously. Does that mean that 2D FAF is no longer the GA diagnostic solution of choice because of the time it takes?
Do you want me to answer this? You
Yeah.
Major? I'm gonna go.
I mean, for me, I still am doing fundus autofluorescence, but not as frequently as I'm repeating OCT. Especially because, like, let's say you have a new patient and you don't necessarily understand how has the geographic atrophy been enlarging over time. The fundus autofluorescence gives you some really important prognostic information as to what's the predicted rate of enlargement in the future that OCT really doesn't. And we can determine that based on the band of hyperfluorescence or the amount of hyperfluorescence surrounding a pre-existing geographic atrophy lesion. Like, the greater the degree of hyperfluorescence, the greater the risk that that patient is going to progress over time.
And Dr. Major, what about FA, right? Because I think, Erin, were you asking about FA versus OCTA? Yeah.
Oh, I'm sorry. I thought you said FAF. I'm so sorry.
No, I did say FAF as well. And then we talked about GA, diagnostic solution.
Well, I'll let Dr. Modi take
Yeah, okay.
more
So,
of those.
I of course it has value, right? Everything has value, but the question is, can you do something that provides you the same amount of information in a slightly less invasive way? Now, of course, an OCTA is not an invasive test. An FA requires the injection of dye into the peripheral vein, which obviously then transits into retinal circulation. But the difficulty is that in GA patients, they have window defects. So they already have a lot of hyperfluorescence early. And then identifying occult lesions, which means hidden, is naturally tricky because it is intended to be tricky. It's below the RPE. And so when you have a large window of hyperfluorescence, and then it's sort of a little bit of areas of sort of like small stippled hyperfluorescence, you say, well, gosh, maybe that's a type 1 neovascularization or occult neovascularization. But an OCTA can provide that with much, much more clarity. And so in this setting, I would say of patients with macular degeneration, the number of fluorescein angiograms that we're doing has been drastically reduced. The one exception to that is if we think somebody may have polypoidal choroidal vasculopathy, in which case we're probably combining that with ICG testing. So we're getting combined FA-ICG testing to help us understand what's called aneurysmal type 1 neovascularization.
Okay.
Great point.
Yeah, that's great. Thank you for that answer. I have another quick question for you, Dr. Modi. What do you see for the future of AM? Maybe this isn't a quick question. It's a pretty big question, actually. But what do you see for the future of AMD and GA management as our AMD patient population continues to multiply?
Yeah, so I think there's two ways of thinking about this. One is the surveillance of these patients. How do we follow them to know that our drugs are working in terms of GA? Like, for instance, if, say, the rate of change goes like this, well, then when you start implementing a therapy, does that slope of progression, does that start to flatten out? Well, we know from the clinical trials relative to placebo that's the case, but how can we know that relative to an individual where there's no associated control? I think that's one of the fundamental difficulties in the treatment of geographic atrophy. So that's where improved quantitative analysis with sub-RPE slabs, time distance to the fovea can be really valuable to help us understand what does it look like 2, 3, 4 years after treatment with these complement inhibitors. And then the other thing is treatment, is where I think we're going to find a lot of patients are going to be treated with anti-VEGF therapy and complement inhibitors. And of course, it'd be great, as the pipeline continues to expand, where maybe we have one drug, there's this sort of bispecific molecule that we've been talking about, which is faricimab. Can a company provide that same technology using a bispecific approach to block both, anti-VEGF as well as some of the complement pathways? And I think that would be wonderful for patients if we can do it with one injection as opposed to all drugs.
For sure. No doubt. Dr. Major, anything that you'd like to add to that on the topic? just the future, for treatment and management?
The future seems overwhelming, to be honest with you. Because if you think about the prevalence of macular degeneration expanding in the near future and even now, and then couple that with like the increased demand for diabetic retinopathy eye care, I think there's so much that we're going to have to handle. And I see multimodal imaging really being part of the solution, and seeing more patients, having more confidence in determining what you need to refer out and what you don't. And more accuracy, right, in staging, whether it's macular degeneration or diabetic retinopathy. I think, imaging is going to play a really important role in how we're going to be able to manage so many patients and so much care that we need to in the near future.
No doubt. Very well put. And certainly that collaborative care approach will play a role as well, as there are so many patients kind of entering into those treatments and management.
We just need to clone Dr. Modi like 10 times, and then we'll be
Well, on that note, if you're sort of thinking about, like, let's go and just say, what does that future look like in terms of surveillance? I think it's also got to come out of the provider's office and enter into the home. And how do we do that in a low-cost way?
Definitely.
And there are certainly companies that are working on this strategy to go and say, can we do surveillance more frequently and in a way that's less burdensome to patients rather than coming into the office? And so I think the future is bright. I think it involves a whole lot of advances, not only in the pharmacology side, but also in the imaging side.
Mm-hmm. That's exciting. Yeah, wonderful comments. Thank you for that kind of vision to the future. So, Drs. Major and Modi, I thoroughly enjoyed speaking with you. Thank you so much for taking the time. Thank you for your valuable insights into AMD management, and we really appreciate you being here.
Oh, my pleasure, and so nice to work with you again, Dr. Modi.
Of course, always a pleasure. And Erin, thank you so much.
Thank you, and thank you to our audience. We appreciate you being here. Hope you enjoyed our session.